Not to diminish cancer in any way because it affects in so many different people. But I think what was most hard for me is there was so much like the NFL and all these different groups with breast cancer and prostate cancer and all these different organizations. And I know it's kind of callous, but I'm like, can we at least give these kids a chance to get to these points? Like we're doing so much in terms of this research, and here are these little guys that are, large killer kids under the certain age. And like, there's just, like there just wasn't anything. And when Kate originally said to me, hey, you ever heard of neuroblastoma? I had never even heard of it. Right. So here's this thing that's affecting these kids and it's so deadly, but yet there was nothing being brought to it. And since we started doing this, Dill here in Austin is now championing neuroblastoma. And so there's more and more people coming to the cause. So I think with some funding, just trying to understand it and more importantly, put some treatments together that give these kids a better outcome.
Yeah, I always tell people, I'm glad you don't know what neuroblastoma is, because that means your family hasn't been affected in that sense. But, there's about 650 cases per year of neuroblastoma in the United States, and the incidence is 10 per million children. So even though it's the most common solid tumor, which means a tumor that presents with a lump outside of the brain in children, it is not well known. And so, yeah, that's increasing the visibility makes people understand why it's important to do something about it. So
is it because 650 cases, so and I know this sounds terrible, like there are not enough data points to really be able to understand like the treatments. If there were tens of thousands of kids, I wonder if there would be more of a 4-alarm fire where now so there's more resources put together and there's more data points and more people are coming to it. It almost feels like with the greater amount of numbers, you get more focus, so you get more chances. So I feel like with 650 kids, like you have to be the pinpoint surgical accuracy to be able to figure this thing out.
You are exactly right. I think that any kind of a rare disease, and children have many of them, it's very hard to do fundraising, get awareness, get research funding. And the other challenge for us, someone who does clinical trials, you need numbers of patients to answer your questions. And so if you're talking breast cancer, you can answer a question that makes a 5% difference in a year or two. For us, we can answer one major question for high-risk neuroblastoma in about 5 years, because it takes we get usually about 100 patients a year on a national trial. And generally you need somewhere around 400 to answer like A versus B kind of question. So it's hard for us because we have to pick what's the question you want to ask among all the questions. And then as we understand more about the disease, neuroblastoma has a lot of different subgroups that are, as we become more knowledgeable, particularly about the genetics of the disease, then those little subgroups need to go off into a different therapy for that particular genetic abnormality. And so that's going to make our challenge even more. But and it's, it's a challenge for pharmaceutical drugs, right? Because it's not a big market. So trying to get, drugs approved for children's cancer in general, is very difficult because of that reason.
I feel like a lot of the research is being done on adults and then they're just trying to like extrapolate it out for kids. Or are they actually designing these for kids, or is it just kind of organisms at different points in life? I've read through so many of these, I don't know what the word is, like pitches almost, where people have asked us to fund trials and like, it's like, hey, this, we tried this drug, it didn't work. This drug didn't work. Now we want to kind of try them together and see if there's a better outcome. Mm-hmm. It's just interesting where you're, like how they're coming up with these, where they're coming from. And it's, and the big problem is the drug companies are for profits. So, they're looking to find, there's benevolent work, you hope, but at the end of the day, they have shareholders and they have people that are looking to turn a profit. And if they invest millions or hundreds of millions of dollars into something that proves it doesn't work, like they have to try to find, and that's another thing where you see so many times like, hey, this new drug hit, it was developed for this, but we actually found it had this side effect that now this is what we're using it for.
Yeah. Well, we always say children are not just little adults. And the types of cancer that children get are different than the kinds of cancers adults get. The way I kind of globally sort of look at it, I think adults, we tend to get more cancers that are more of mature tissues, so like lung, breast, brain, and these are oftentimes there can be environmental factors like smoking or your diet, those kind of things. Children tend to get more what we call an embryonal cancer, so they're like very early primitive cells, babies, if you were, that, don't know the rules of the road yet, and they persist in that immature state. And the good thing about that is they tend to grow more rapidly, which makes them a lot more sensitive to many of the standard chemotherapy drugs. And actually, our cure rate in children is much higher than adults, for overall cancer. I mean, because leukemia, the most common cancer now in children, has about a 90% cure rate. So when we're looking at drugs, we definitely, we have a number of people that work in the lab, and they're looking at all these different mechanisms that impact neuroblastoma. So when there's findings in adult cancers that are similar, like melanoma or non-small lung cancer bears some similarities, we look at what works there, and then we try it specifically in a neuroblastoma model in the lab. So it's not just, oh, it worked in adults, so maybe it'll work for us. We actually look for specific data that it works in neuroblastoma. And we actually have done, now there are a number of trials. There's a drug, dinutuximab, which is a monoclonal antibody that was just recently approved for neuroblastoma. And that, again, it does have positivity in melanoma and some bone tumors, but it was approved for neuroblastoma. So sometimes we have drugs that, are very specific, and sometimes we take an adult drug and trial it out in the lab first and only move it forward into patients if it looks promising. But we also do look at if a drug has an adult indication, meaning that it's going to get marketed for breast cancer or prostate cancer, it's much more likely to be around for us to use. But we may use it, in a different way, different doses, different schedules, combined with other things. So the adults learn from us, we learn from the adults. I like to look at it as a interchangeable,
symbiotic
funded knowledge. Yeah, absolutely. Yeah.
Can you get into a little bit of for the listeners who aren't familiar with neuroblastoma, like what it is, how it affects? It grows in the nerve tissues, but really how it, and that's what we know about the standard neuroblastoma. But then there's also these different variations. Like I see all these different names that tied to blastoma. It's like glioblastoma and this, and there's all these different pieces. So I was wondering if you could just give us a little bit of roadmap to help those at home that are just not as educated on it.
Sure. So usually the blastoma usually refers to kind of those more primitive types of cells. So you'll see that blastoma root in a lot of, different cancers, and neuro obviously refers to the nervous system. So a lot of people think neuroblastoma is a tumor of the brain. It is not. So it's a tumor of what we call the sympathetic nervous system, which is your unconscious nervous system. It controls your heart rate, your blood pressure, kind of like, I look at it as your idle rate, like a car. And so it's always working, and it gets activated in times of stress, or it's called the fight or flight system. So like if you're agitated, you have to run, your blood pressure goes up, your heart rate goes up. So that nervous system regulates all those things. And the sympathetic nervous system, where it is located, there's a gland on top of your kidney called the adrenal gland. And part of that is part of the sympathetic nervous system. And then there are nerves from it that run up and down either side of your spine. And then there's some clusters of nerve cells, like there's one in the neck about here, which is called cervical. That's the Latin name for neck. And so that's where neuroblastoma occurs. It most commonly arises in the adrenal gland on top of the kidney as a lump. Or it can arise on either side of the spine, or or in the neck. And in about half of children, when they come to being diagnosed, the tumor has spread from where it started to other parts of the body, and typically into the bone marrow, into the bones, sometimes the liver. And then very young children, infants, can sometimes present with like these we call blueberry muffin nodules. So they look like a blueberry under the skin. It's a blue nodule, or like a very big liver. So there are some, peculiar things. 90% of kids with neuroblastoma present under 5 years of age, and the average age is 19 months. And I think one of the important things about that is, if you think about it, hits a lot of families, young families with their first child. And that's right, you're still getting used to a toddler, and then you've got this to deal with. So I think that is a big impact of this tumor. We do see it in young adults. It's much less common in teenagers and adults, but the oldest patient I've seen was 40 when he was diagnosed. So it does happen, rarely in adults, but predominantly.
Adam from CrossFit LA and Venice, he had it as like a 26-year-old kid. He had neuroblastoma.
Wow.
Yeah, I mean, and so I always thought it was just, like after the age of 5, they were kind of out
Right.
away from it. But then
Right.
there's these cases of people having it later in life, which seem even more wild that we would know one.
Yeah, and it is what makes those tumors tick is different than the younger kids. Usually once the older you get beyond 5, you tend to have what we call like a slower paced tumor. So like under 5, the tumor tends to grow very rapidly. Your treatment either works or it doesn't within a few years. The older patients can go, I had one patient I treated for 21 years, presented when he was 10 and sadly passed when he was 31. So it's a much slower pace, and it has different genetics associated to that group versus the young kids. So again, there's all these, subgroups of once you have neuroblastoma. And I guess the big dividing point is about half the kids are what we call high risk and about half are non-high risk. And the kids with non-high risk have a 90% chance of survival. They do very well. And our focus there in terms of treatment over the years has been defining more and more who does not have a big risk and making the therapy less, getting rid of radiation, getting rid of drugs that might be harmful to the heart or the kidneys, giving a shorter period of therapy. Sometimes in some of those patients now, we just watch them and it goes away. The high-risk kids, the focus there has been, we're still at right now 50% survival. That's improved from 29% when I started out in this field 30 years ago. So we've doubled, but we have certainly a long way to go. And there it's basically, we've intensified therapy in terms of dosage, to the max. And so now we're really trying to work again on refining who are the subgroups that we could do more what we call targeted therapy. So if they have a specific abnormality genetically, that we could find a drug that targets that instead of giving a drug that generically targets any rapidly growing cell, which is kind of a global thing of how chemotherapy drugs, many of them work.
When did we start looking at cancer genetically? Did that change over the last 30 years?
Yes, absolutely. When when I was in my fellowship, now I remember, we started doing a number of like genetic recombination things. And Dr. Seeger, who I worked with at Children's Hospital Los Angeles for many years, he published a gene called Mibg, which is still one of the most prognostic genes in neuroblastoma. And they published that in the 80s to say that was a very strong marker. If you had multiple copies of that gene within the cancer cells, they would multiply copies of this gene and it made the tumor grow very fast and very resistant. And these kids had a much worse outcome. Now we can actually, the techniques that are available now to do genetic analysis, you can now do it instead of a big chunk of tumor that you need to work with. We can do bone marrow samples with a few cells. We can do blood samples and look at circulating tumor DNA. And so the techniques for that are really, they're rapid, they're smaller specimens, less invasive, because obviously drawing blood's a lot easier than having to take a chunk of tumor surgically. So we can get a lot more information. The things we're still learning, how do we use that information? And we may find pathways genetically that are abnormal, but how do we target that? The body is very clever at having more than one circuit. It's not just like A goes to B, go to C. If B gets abnormal, it finds a detour, and then you find a detour here. So it's never usually as simple as, okay, you have this one genetic abnormality, target that, oh, you're done. But it always adds into the knowledge, and it definitely has, brought us forward to have all these techniques.
Do you think that the neuroblastoma is growing in vitro? Like, is this something that's, like as the baby's developing in the mother's womb, this is present, and then now we're seeing like the child, because these kids are getting so like hit with it so young. Mm-hmm. I'm like, does it have enough time to, create and grow, or is it something that's happening earlier on in vitro?
Well, this is the $1 million question. What causes neuroblastoma? And we don't know that. There are some rare familial cases where children have all the cells in their body have an abnormality in their genetics that leads to neuroblastoma. That's very rare. We do see neuroblastoma diagnosed before birth, especially now that many moms are having ultrasounds. find a mass. And generally, those children do extremely well. They generally have the non-high-risk disease. Many of them can just be watched and the tumor goes away. And we have a very non-invasive test to help diagnose neuroblastoma. You take a urine sample and you measure these chemicals that this tumor makes in high levels. And so you can say if that level is elevated in the urine, you can say this child has neuroblastoma. So there have been 2 screening studies done, children like in the first year of life, because again, the average age of presentation is toddlers, 19 months, to say, well, could we catch it earlier, when it's just a little tiny thing, and we'll get it out, and then it won't turn into this thing that's all over the body and high risk and very hard to cure. But what was found out is that the children that were diagnosed with those early screenings were all in the non-high risk group. So they were probably many kids that never would have presented. And we know that children who died for other reasons on autopsy, you can find evidence of neuroblastoma. So there is this very young children that spontaneously it resolves. And we don't totally understand that, but we don't think those children become the high-risk kids. It's a separate set of events that probably leads to those 2 different scenarios.
Well, I guess, we only have 2 options. It's either genetic or it's environmental. So, it's kind of, and I'm sure like you said, it's like the $1 million question. But I guess once it comes down to it, really almost doesn't really matter how it happens. It's just how, like, once they get developed it, and how do we treat it, and how do we increase survivability of this? Because it feels like, at least with Wade's deal, once they go through all the chemo and they fight it off, if it comes back the second time, they don't have the strength or the resiliency within the immune system, I think, to fight it off. Or is it just that it comes back so aggressive the second time that it just ends up being the final straw for them?
Well, that too has changed. I think that we have gotten better, number one, in terms of getting them through the first line of therapy for the high-risk kids, which is about 18 months, and it's very aggressive and intensive. But we've learned to manage that with, good supportive care, so the child is able to tolerate more therapy if the tumor comes back. I can tell you, in the 80s, when I started treating neuroblastoma, if a child had recurrent tumor, their average lifespan from there would be probably no more than 9 months, and many of them died within months. Now we have children with recurrent tumors who are living years. And again, I think this is because we have new therapies that have different mechanisms than what they got originally. And they're not as toxic to the whole body, so they can be tolerated. And in terms of the immune system, it absolutely still does function in kids who have tumors that recur. And then we're also using drugs that enhance the number of immune cells. And we're actually even giving back some immune cells to the children, these cells called natural killer cells, where we're taking a blood sample from the patient and taking that to a laboratory and increasing the number of these cells in that sample, and then giving it back to the child to help them have more cells to fight the tumor. So
yeah, that's like the culturing outside the body and putting it back. And yeah.
Right. So immunotherapy, as you probably know, is a very, hot avenue in all of cancer right now. And particularly in neuroblastoma, because of the monoclonal antibody that I mentioned, that made a significant difference in survival for children with neuroblastoma. So that was the first proof that immunotherapy works. And so now we continue to try to figure out what's the best way to do immunotherapy, adding something to that. At what time point do you give that drug? So immunotherapy is a very, very active avenue, and definitely something we learn more every day. But it's going to be, I think, a very important impact on the outcome.
When you guys do the biopsies on the tumors, obviously you kind of do a genetic workup of the tumor. Are they all different, or is there commonality in all of them? I'm sure there's identifying factors in the neuroblastoma, but I wonder if like the genetic markers are the same, where, they're specific to the individual, or is there really just a bunch of common ones that you're like, okay, these are the common ones that we're finding, we just don't know necessarily why they're expressing?
Mm-hmm. There's, in terms of the genetic analysis, there's a standard panel, that is done in children. And certainly there's ones we know, like Mibg, for example. I could name a bunch of other genes with their nomenclature, but there is a standard panel that we know are typically abnormal, and that help us to decide what treatment to give them. And then we are now, like, for example, we just finished a trial we call precision therapy, which means looking at the genetics and seeing, you look to see if one of the abnormalities that they have has a drug that matches it. So like there are certain drugs that, target the RAS pathway, just to give an example. And so if a child has recurrent disease and they have an abnormality there, then we would tend to choose something that targets that pathway, maybe combining it with chemoimmunotherapy or whatever. So we do absolutely use that information. Children's cancers in general, though, do have neuroblastoma, and children's cancer in general have fewer genetic abnormalities than adult cancers do. So, we have fewer things to target than many of them do. But again, and it changes over time. So we also know that the abnormalities that are present at diagnosis, after you get therapy, they change. They may go away and come back, the same ones, or you may get new ones. And this doing a blood sample to get the circulating tumor DNA is a really exciting, technology now, because you can look as you're treating to see, okay, is this abnormality going away with the drug you're giving? And is something new there that we should change the therapy? So again, we're still learning the best way to use all that information, but that's a really elegant piece of information versus me just doing a scan every 3 months and saying, did the lump get smaller? And I don't know why. Now this is telling me kind of what's in there making it tick. So that's really helpful.
You're based out of LA, Southern
Yes,
California?
Children's Hospital, Los Angeles. Yeah.
Is how many places would you call like centers of excellence, or really just places that are really fighting neuroblastoma? I mean, when we started this 10 years ago, there was only a handful. I just wonder if that's increased or if it's kind of like still kind of focused in different areas.
Well, as you probably know, different children's cancer centers will focus in different ways. We are the lead center and part of a consortium called New Approaches to Neuroblastoma Therapy, which we started in the year 2000. So we just celebrated our 20th anniversary last year of that. And we have 12 sites around North America that are participating in that, which are all very focused on neuroblastoma, have a lot of expertise, see a large enough number of patients to be part of that consortia. And outside of that, there's probably like another, I'd say like 8 to 10 centers. And again, I know when I first came to Children's Hospital and we were doing transplants for neuroblastoma, there was only maybe about 4 or 5 transplant centers around the country that did neuroblastoma. So we got patients from all over. Now transplant is a widely used technology. And so it's done at most, hospitals that have a significant population. So I think that number is always changing, but it does take a lot of expertise and different laboratory support and different specialists to support a neuroblastoma program. We need surgeons, we need radiation oncologists, we need pathologists, we need all the supportive care people in the hospital, infectious disease, cardiology, kidney specialists, intensive care. So you have to have all of those things to be a major neuroblastoma center.
Yeah, that's, as John mentioned earlier, a big mission. Family that's living remotely or far away from the center. Parents got to take leaves of absence from their job, uproot the families. So we aim to provide financial support. Another big branch of our fundraising is funding research. Mm-hmm. How important is private funding for neuroblastoma research in empowering people like Los Angeles Children's Hospital?
It's absolutely critical. And I tell everybody, every dollar you give does make a difference. It really does, because ultimately, we apply to federal grants. And as you know, the federal budget is, I don't need to explain that.
Yeah, so, no. And the fact that we're laughing about it just is all we need to get into. Yeah.
Exactly. And if you look at the federal budget for cancer, only about 4% of it goes to children, sadly. Yeah. And so that's something. And so for us to go for those types of grants, we really have to have a lot of data to say, well, we did this, we did this, we did this, and now you should fund this bigger project. So we have to start with small funding. So we'll do a lab project that leads us to an exciting finding that we say, okay, let's use this and design a trial where we can treat kids with this idea. And we do that in a consortia like our New Approaches to Neuroblastoma Therapy. And each of those clinical trials costs about $25,000 per child. I'm not talking about the billing to the insurance. I'm talking about what it
hard cost
to do all the monitoring and the data keeping and the federal safety approvals and things like that. So that seed funding, generally every dollar of seed funding we get probably can yield $15 in future grants. And you have to have like an infrastructure, like an office, people who are competent and know what they're doing, ready to go. So when somebody in the lab comes up with a great idea, you can say, we're ready to run with it. We don't have to build it before we can go.
That's a powerful statement in itself. $1 potentially leads to 15. The challenge with fundraising where we're saying, hey, you get a $35 t-shirt and then leading to a $25,000 per.
I played in the NFL and there was a lot of charities that were supported by the NFL. The problem is that I think a lot of money was generated, but I was always a little saddened when you actually see the dollars that actually get contributed. Like the NFL like raises X amount of dollars and they're like, we give 5%. And I remember thinking like, not that it's disingenuous because I realize people are trying to make money, but I think it's tugs at the heartstrings as a parent when people are raising money especially for pediatric cancer. And, the money's going to all these different infrastructures and such a small slice is going to where it really needs to go. So when we started Wade's Army, we wanted this like, very transparent, like every dollar that we can give, we give, and there's oversight. We're just not, randomly giving it out to this. We wanted to support, like I remember, the one family, the kid was in a wheelchair. They didn't know how to get him around. So they hit us up. We bought him a minivan because they were, like they had to get around and they had to get to the appointments and they had to get a wheelchair in and they didn't have the money for it. So just being able to support those people, like those are the stories that I appreciate, but like also having a little oversight where, like I want to see some advancement. I want to see people outside the box thinkers coming in and trying new things, just not trying to recycle the other stuff that, hey, the drug company has spent a ton of money to try to develop this drug. It's been proven to not work. Let's continue just to try to drive it in there and see if we can find it for something, but more innovative stuff. So whenever we look at any of the grant or any of the requests for the studies, I just want to read innovation. Like how are we using technology, the testing aspect, whether it be genetic or, markers in this and, whether it could be as simple as like micronutrient deficiencies, like what, like, and I know it's not that simple, but like just trying to jam the drugs in there, just kind of, as I was reading these things being like, God, like this is like, where's the innovation? I like to think like we have cell phones, we have all this technology. We're sitting here talking on Zoom, like, why can't we get more into that space into trying to fight this?
Yeah. Well, let me give you one good example. I think that will illustrate kind of this whole spectrum. So there's a gene called ALK, which is abnormal in about 15% of neuroblastoma diagnosis and maybe more as they recur. It's also present in non-small cell lung cancer. So there was a drug designed to target this called crizotinib, which it's an FDA-approved drug. And we have a trial going in the Children's Oncology Group, which is a national consortia that does those A versus B trials for 5 years, the really big ones. And they have a trial going where kids who have an ALK abnormality go on to a special arm of this trial and they're getting crizotinib. So meanwhile, Dr. Yael Mose, who's one of our colleagues in NANT, she's at Children's Hospital of Philadelphia, she has studied the ALK gene in her laboratory for many years. And the problem was that a lot of tumors could be resistant to crizotinib. And so she started studying a second drug that targets ALK called lorlatinib. And what she found is that it would kill a number of the tumor cells that were resistant to crizotinib. And it had a favorable toxicity profile. So within our NANT consortia, our 12 institutions, we are now conducting what's called a phase 1 trial. So that's doing what's the side effects, what's the right dose. And that trial has had very promising results, and both in terms of it's tolerable, we're seeing exciting responses, we're getting the drug levels that we need, we know from the lab we need in the patients, and they can do okay with those. And so even though that trial is still ongoing, we have enough results that the Children's Oncology Group is now amending their frontline study to change to lorlatinib from crizotinib. Oh, wow. So there's what we call a bench to bedside. So it started out with her lab. She proved all these things. And even during the trial, she found that neuroblastoma needs higher drug levels in the lab than lung cancer did. And so even though there's a dose established for lorlatinib for adults, we are pushing it higher in kids because for neuroblastoma, you need a little more. Mm. So again, it's very specific. It's very evidence driven. And this is one of the trials where we're testing circulating tumor DNA. And we can see over time in the patients on the trial, sometimes their ALK abnormality is there and it goes away. It may come back before we see something on the scans, or it may change, be a different abnormality in the ALK gene, maybe some additional abnormalities. So this is really elegant data to help us figure out, how do we best use this drug? And, how do we, maybe, patient one needs to stop it after 4 times and go on to something else. But this other one, you can see that it's going away in the blood, so keep going. So it gives us an earlier marker than our scans. So I think that's a really elegant example of how a smaller consortia like ours that has just a lot of very focused expertise and very labor-intensive trials of new drugs that you really have to watch closely. And we get all that work done, and then we can go to all the centers around the country that do the children's oncology group trials. And those involve many smaller centers that don't have the same expertise. But by the time we've done all the safety and everything, we can tell them, this is how you give this drug safely. And, you can do this now. It doesn't just have to be at a specialty center. And again, if you can't come up with treatments that can go everywhere, right? It has to go to North Dakota and South Dakota where there's not a lot of big medical centers, I trained at University of Minnesota in my fellowship, and I had patients that were 6 hours away through 2 feet of snow and minus 60 temperatures. You have to find something that can get to everybody, right? Or, you're not doing your job. So
What's like, it sounds like this, I guess it's the screening is not wrong, but like as the testing and like the fact that you can almost like you said before, you were using scans and did it get bigger and lower, but now you've kind of drilled down and it's like such more at a much more like granular level to now you're not having to go in and biopsy the tumor. You can check it for blood. Like when did that kind of enter the like the arena where now all of a sudden you just found much more sophisticated and, as you said, elegant forms of being able to like test and figure out the efficacy of each of these drugs? Because I remember like 10 plus years ago when we were talking with these doctors, they were even talking about, still doing these scans and trying to figure out the tumor was kind of growing and different sizing. But it sounds like now we have all these, much more technology based to figure out in real time if this stuff is having the effect we're thinking it does.
Well, I don't mean to say that we are not using that yet as our upfront response criteria. We are still using scans and bone marrow tests where we actually put a needle into the hip bone and sample the bone marrow. The wave of what's going to be next is always in experimental trials right now. And I think that's where the genetic things. There are some abnormalities that we use at diagnosis to put you into the high risk or the non-high risk category. But in terms of changing therapy based on these tests, we aren't, we're still learning what's the best way to do that. So, and I would say in terms of the radiology aspect, that also has been a huge advancement. Again, when I started, MRI did not exist. We now have scans, we have very elegant detailed CT scans, which are like slices of your body. So if I could slice your body like this, and we combine that with a nuclear medicine test that I kind of like to describe as like a Rorschach blot. So you inject something into the bloodstream of the child, and where there is neuroblastoma, it lights up. And that's very specific for neuroblastoma. So we can fuse those two images. So like you get a color that lights up the bone where you might see an abnormality on the CT scan. So we're able, just the diagnostic ability of the radiology that I have available to me now versus 30 years ago is phenomenal. So that's also another advancement. Our response criteria that we use to grade response on these trials and to change therapies is still based on radiology scans and some bone marrow tests. And we are not, and we do have some sensitive tests to look for what we call minimal residual disease by blood samples and bone marrow samples. We're still trying to find what is the optimal technology to do for that. So I'd say that's where we are now. And if you're treating a patient typically who's got relapse disease, those are all pieces you put in your head because there's not a standard pathway. There's not a proven cure for a tumor that comes back. So you consider every single piece of information you can get. You look at the scans, you look at the genetics, you look at all these minimal disease detection tests, and then you decide what's the best way to go for that patient, even though some of it's not, fully established, but it's like, it's a piece of information you have as a clinician to share with the family and say, this is why I want to choose this next pathway for your child.
I was thinking like adults, it's almost like lifestyle, like you talked about, like diet, exercise. I mean, all these, overweight. I mean, there's all these like risk factors that put people at risk for cancer, lifestyle, lack of sleep. I mean, all these basics, and these kids are, should be kind of healthy coming out, and how now they have this issue. Is there ever a time where there's other compounding things going on more so than just neuroblastoma? Like I always wondered if, because, somebody has, high blood pressure, or they have all these other risk factors, and then they get cancer. Whereas these kids are, by most standards, pretty healthy, and then all of a sudden the tumor starts to flow.
Yeah, that's usually the case. I mean, again, it's we have not yet found any environmental factor that causes or contributes to neuroblastoma yet. So we don't know if there is one out there. We haven't identified it, so we can't say that. And generally, and I think that's one thing about treating children for cancer is you are able to use more intensive therapies because they are very healthy, their organs recover very quickly. And we know, sadly, that there is, like higher doses are more effective. And we've proven that in neuroblastoma. But obviously it does have side effects, and not just medical, but again, these are young families. They have other kids in the family, they have work lives, they have other family members. And so I think that that's one thing about pediatric cancer. We are very much at our hospital, and I know all of our neuroblastoma centers, it's very much a team approach. We have child life, we have social workers, we have nurses, we have a lot of, because that is just as important as getting the right medication, because it's a huge impact on parents and the other siblings and the rest of the family.
Yeah, I was just re-looking up 4 of the studies that we've funded over the years, which is fairly interesting because now 2017, looking up, and now a lot of the terms you're introducing, which meant nothing back then, now the ALK, the ALK inhibitors and things like that.
Well, people always ask me, they're like, hey, what about that study we funded? Any progress? And I'm like, it takes like 5 years to run the studies. And then after that, you have to have like the data crunch. And so like things that what we're funding today, like are hopefully we'll see in the future. Like, it's not like, hey, we funded it today and then 6 months from now we have information. Believe me, we check in, but like the studies take a long time.
Linked up at wadesarmy.org/neuroblastoma. And so one I was looking at here, phase 1 clinical trial, and started in 17, and then just clicking through and we link up to clinicaltrials.gov. And it shows the progress, the data, when it started, when it's concluding, and I guess some updates that are well above my pay grade. But it interesting in that, and as John mentioned, the aim is to show you exactly where all the fundraising is going. And while it may be a $35, a large group of people each year come together for $250,000 to then,
it's
like 10
it's
kids
like
right there.
It's like crowdfunding. Instead of going out and finding maybe 1 or 2 donors, I feel like you get a team, and that's why it's called Wade's Army. Because I remember when my wife pitched me this idea of doing something, I'm like, man, we're going to need an army of people to try to fight pediatric cancer.
Exactly right.
And that's where it started. Because it'd be nice if everybody could just stroke $1 million check and just basically just buy this thing out of existence and be like, you know what, I don't want kids to ever have cancer. I'm Elon Musk. I'm writing $1 billion, and we're giving you all this technology. And unfortunately, those guys are making solar panels. And, so I think the crowdfunding way of going about it is allowing everybody, because what's extremely heart-wrenching is, as we've started to do this, the amount of people that have come out that have either had a family member or a friend or somebody they knew affected by neuroblastoma is like, 1 degree of separation from everybody.
Right.
So you think for, would you say 620, 650 kids, 665 kids a year. And yet, here's a country of 330 million people. And then, globally, our reach to have this many people affected by it just makes you realize how interconnected we are as a population.
Yeah. I know, for our donors to our NANT organization, I mean, we very much honor, different donors have different passions of where they want their funding to go. And we feel very strongly about honoring that. Some people want to support lab tests. Some people want to support, the kids' travel, whatever. I mean, those are all important. They're all essential to getting things done. And we certainly will provide an update of where we're at, because, generally our studies, after a year of our study, we can certainly tell you some, significant information. We've entered a number of kids. We know the drug is what its side effects are. We typically in our dose finding studies don't talk about our response data until they're far enough along, because otherwise, people you don't know if the first 5 children don't respond, the next 15 will. And so you don't want to, harm that trial by somebody thinking, well, I shouldn't enroll. We have to function with statistics, right? You want to get the right answer. I know one of the questions we were talking about is like, why are consortia important? And that's because, like, if I just looked at the kids that I treat at Children's Hospital Los Angeles, I have a random chance of getting kids that do really well or really, badly in response to therapy. When you have 12 sites, and we are spread geographically across the country, also to try to help parents not to have to travel so far, when they need therapy, we want to try to give everybody something that's within reasonable access. That we can put all those numbers together, and that's how you learn. And it's totally a partnership between the parents, the families and us, because they're putting their trust in us to put their child on a trial that's something new, and we don't know everything about it yet. So how we learn.
Can you talk about the families that are willing to participate in the trial? Are they've tried 1, 2, 3 opportunities, nothing's worked, so now we're gonna roll the dice on this trial, or is it one of their first options?
In newly diagnosed neuroblastoma, those trials all are through the Children's Oncology Group. So again, that's a national group, which we are part of. And it has about close to 200 sites, around North America that participate. And there's a group of us that sit down for each type of childhood cancer, leukemia, neuroblastoma, brain tumors, look at all the things everybody's doing and try to design the 5-year questions. Is A versus B going to make more kids live? That's basically usually the question. So, those trials are, available, broadly to everybody. And I think families come to clinical trials in many different ways, as you can imagine. Some families are more educated. They're on the internet. They're looking. If you're in a big city like Los Angeles or Philadelphia, it's kind of easy to find your way to somebody like me, who can say, okay, here's all the things that are going on. I've met patients at some of the parent symposia that were in smaller states where there weren't big centers, and they're like, I just went to my local doctor. I had no idea all these trials were out there. So there's that, and there's some families that don't have the finances to travel. They don't have them. I mean, I've had patients that didn't have the gas money to come an hour sometimes, and we had to help them from our social workers. So I think everybody has a different comfort level with clinical trials, and probably the Children's Oncology Group trials are based on a lot of prior data. They're much farther along in the experience. The things we're doing in NANT are obviously many times, the first time we're using a drug in children with neuroblastoma. So that's a different risk you're taking. I think for most parents, when they're diagnosed, neuroblastoma is a foreign word. They don't know what a blood cell is. They don't know what a kidney function is. Talk to that parent a year later. I mean, they're so savvy. They can talk to you about ALK and immunotherapy, and they can give questions that challenge me, So, and so those parents are obviously, they're out there reading and searching, and they're going to a lot of, forums where we present and other groups present, and then they seek out that therapy. So I think the answer is it really depends on the family and, their educational and financial and social resources. So.
Yeah, connecting with some families that applied for our grants. Sure. And hopping on the phone with them, with Heather, and then she's essentially got a PhD in all this stuff.
Not only did she, go through it with Wade, but then in the last 10 years, we've been evaluating all these grant proposals, and she still stays very connected, and the social workers and the doctors and people, to the point where people have said, hey, I don't have the money. And they've been like, well, let me connect you with this person. And, we've read the requests. And I remember being like people would ask for a specific amount of money. And I remember being like, can I give you double? Dude, I'm not going to send you $250. Like, let me send you $500. Like, use the money wisely, like do something with it. It's just, I mean, and I'm sure, Doc, you know more than, we do, but like the stories are so harrowing. Like, you hear this and you're like, God, like my heart just broke 100 times. And, I mean, obviously the child going through it, at such a young age doesn't understand it, but the parent, that feeling of helplessness where, like, this is happening to my child and I can't do anything to help them. Like, that's the worst part of it.
It is the worst part. And I mean, I think I always tell parents, I think you need to feel you turned all the stones. And if people want to go for second opinions or seek other things, I think we're always like, we'll give you a medical summary, we'll help you find the right person, we'll give you their contact number. I mean, the neuroblastoma investigator community, the pediatric oncologists like myself, we're a very close-knit community internationally. And I think, we all want to find the answers for the kids. So it doesn't really matter whether I find it or someone else finds it. You want to work together and share your information. That's the idea of consortia, that you're putting the best minds together so you have all the information you can possibly have to make the best choice you can. And, those choices have changed over the 30 years that I've been doing this. And thankfully, I think that we have eliminated a lot of toxic things, and yet our survival is improving. So, but it's painfully slow. I mean, to still be at 50% is not where you want to be.
Is it like, are the global numbers of neuroblastoma in line with what we see here in the States, or is it something that's bigger here or bigger in other places? I just wonder, like, I mean, it's if you look at like adult cancers, there's some really interesting like pockets of where certain cancers affect certain people, like, stomach cancers in this pocket in here. And there's other countries that don't even have this stomach cancer. So it's pretty interesting when you start kind of tracking. I just wondered if, and I've never looked at it actually, if neuroblastoma is kind of globally, if the numbers are pretty consistent.
Yeah, there's not geographic pockets like there are for, for gastric cancer or, some other tumors. But I will say, like, that in, lesser developed countries, we don't probably really know the incidence, because kids don't present until they're really extreme, have tumor in a lot of places and are very sick. I think those are the hardest things when, we get emails from families like that who are, are desperate for help. And it's very hard to, where medications aren't available. And that, that is still a struggle globally in our healthcare system, of course, that it's inequitable in terms of treatment. In this country, we have, in major European countries, we have all these various, specialized therapies available for neuroblastoma, but that's not true everywhere.
So yeah, so the global numbers. So it's not necessarily something environmental. I mean, like you were saying, you never found environmental.
Yeah, as I said, not that we have not yet identified an environmental factor for neuroblastoma.
But I kind of always have always thought that it was something genetic, but I always wondered if there was genetically tied to a certain ethno group or, group of people, certain people of certain descent. But I remember kind of digging in, and there was nothing to tie any of that stuff together.
Yeah, it's a very small proportion of neuroblastoma that has a known genetic driver. So that's a very small number of cases, and you'll see like several cases within a family line of neuroblastoma. So most of them, we do not know what the causative event is. We don't know if we're assuming there's some genetic event that primitive tissue, instead of going on to become sympathetic nervous system tissue and doing its job like it should, it persists as an immature type of tissue that doesn't follow the rules and grows too fast and goes places it shouldn't. But we don't know ultimately what the driver is for that. And that's how you cure cancer, of course, if you could find that driver and stop it, or find the factor that leads to that driver. And we do not know those two things.
Do you put a ton of research into that, or is it more like triage, like let's put our time and effort into helping the kids that are afflicted with this more so than going out and looking at, I don't know, like trying to figure out the cause. Whereas I wonder if, like, farther down the line, if we were to figure that out, you could almost do a screening ahead of time to know that, hey, you know what, like, these two genes and this gene, if they express in this way, it's going to give you a chance of this. And, as a parent, you could be, screening.
No, that would be wonderful. Well, I mentioned the urine screening study, which, turned out that was not an effective way to screen. when we look at the abnormalities in the genetics in the kids who actually have neuroblastoma, but then, you go back and look at diagnosis. Like, how many kids actually present with that? And if you see that commonly, then you're going to say, well, maybe this is the driver. They all have this one gene, and then they get the second thing, and then that leads to the cancer. But so the thing that raises your flag is what's in the kids that have actually presented with it. And then you go back and you look. So I think there definitely is research into both, because, we could stop doing all the other research on treatment if we could figure out how to predict you're going to get it and just catch it early and do something about it. So one feeds to the other. Absolutely. If there's familial cases, those get studied to look at what are the abnormalities in those families. Maybe that'll help us in some of these other cases.
Is it something, definitely, like, the earlier you catch it, the greater the outcome?
No, and I have this is interesting, because one of the moms of one of my patients right now, we're working on a project to try to work with pediatricians to help decrease the delay in time to diagnosis for neuroblastoma. She found in surveying a lot of parents that, a lot of the kids, her own daughter included, present with vague symptoms like constipation or irritability, don't want to take a nap, things like that. So we're trying to figure out, how to make that gap shorter, right? And educate everybody. So, we're kind of trying to approach the problem from a variety of different angles, but it's tough when you're in a pediatrician's office and you have, 10 kids who come in with constipation, and maybe one in, 100,000 is going to have neuroblastoma. Who do you do a CT scan on? Who do you do an ultrasound on?
Well, then also, as a parent, you don't want to believe it's your kid.
Exactly.
Like, my little boy got diagnosed with type 1 diabetes about 5-6 months ago, and I saw the telltale signs. Like, he all of a sudden, like out of nowhere, started wetting his bed. And so I was like, oh, this is kind of weird. Why did he regress? And I'll throw a diaper on. And then it was like, there was all these, like, little things that I should know. But, like, you're like, oh, it's just a kid. This isn't, like, this happens. And you talk to other parents like, oh yeah, my kid regressed to like 3 years old, 4 years old. And so now I, like, think about it, and I'm like, man, like, I know these telltale signs. And we talked about it on the podcast, and a guy hit me up that it was either son or daughter was having similar things. So they took him in and got him tested and figured out that his blood sugar was super high. And he was in this
so you
kind of,
educated.
so somebody took the information, like,
Right.
oh my God, like, this is happening to me. And I think unless you have, podcasts like this, or you're around this type of information, maybe it gives you, like, arms you with the information as a parent, because it's real easy just to be like, oh, it's not my kid. He's fine. Everything's healthy. This is just something. But as you're saying, like, here's something where, constipation and, irritability and some of the other things, like not taking naps. The kid could just be colicky and not like to nap.
And usually they are. And I think the reason I was bringing that up is I think that puts a lot of guilt on the parent when they finally get to the diagnosis, thinking, well, if I'd been here 9 months ago, things would be different. So my bottom line is that with neuroblastoma, it is what it is from the beginning. If it's high risk or not high risk, which is a big difference, it is what it is. If you were here 9 months ago, even if you had less of it, it would still be high risk or non-high risk, whatever it was. So really, we have not found in neuroblastoma that delay changes, what the child's outcome would be. In the sense that if you let it go and it starts, sometimes neuroblastoma, for example, can make tumors behind the eye and squeeze the nerve to the eye. So like if something, or it can be near the spinal cord and press on your spinal cord. So those things, obviously, you need to, take care of, because they start to cause harm from the location. But in terms of the aggressiveness of the tumor and its risk of being cured, that does not change. And I always talk with parents about that, because whenever I say that, 3 or 4 moms will just say, thank you, I'm so relieved, because, I've been living with this guilt because I kept telling my doctor and they kept saying, oh, she's just irritable. She's, whatever, having problems at school. And then obviously as a parent, you feel like I should have known, and I don't want people to chastise themselves for things that, it's not their fault.
It's an excellent question.
No, the guilt associated with any, like, childhood illness that happens as a parent, like, you think, like, I'm the parent, I'm the one in charge, I should know this. And you're, it's like, it doesn't matter what it is. It's, I'm in a Facebook group for, like, parents with, like, type 1 diabetes kids. And, like, these parents, you could almost feel, like, the compensation patterns of like trying to be like so adhere to all this stuff because out of some guilt. And like at the end of the day, you just work within the framework in which you're presented and you do the best you can. And if you got to carry a little bit of guilt around, that's called parenting. I'm sure our parents have got plenty. I'm sure everybody, my mom constantly asks me, was I a good mother? I'm always like, oh yeah. And then my brother and I will roll our eyes, like I was nice to you guys. We're like, oh, define nice. It's different by today's standards, but it's it's a sad thing to deal with. I just, what's on the horizon? Like, is there something that you're really excited about? I mean, the immunotherapy, I remember reading a bunch of stuff with cancer and like the CRISPR where they were talking about gene editing. I mean, there's been some really amazing technologies. I wonder like what's on the horizon? Like, what do we keep our eye on that you feel like might be something that's going to crack this code a little bit?
Mm-hmm. Well, I mean, I think, the genetic information coming out is going to continue to unlock secrets about this tumor that we can exploit to develop new treatments. Because if you know what makes it tick, you can go after the tick. I think some of the things that are being tested right now that I think are positive, we've been doing a number of trials over the years with Mibg, which is it's called a targeted radiotherapy. So I think people are kind of familiar with X-rays, and if you get radiation treatment, you stand next to a machine and it emits a beam and that, hits your cancer and kills the cells. So instead of doing that, we have a radiation that is in a liquid form. So there's the molecule actually floats around and finds the neuroblastoma cells inside the body, wherever they are. So again, you're not like radiating through normal tissues and damaging them. You're putting the drug in the bloodstream and it goes to where the cancer is and is absorbed into that cell and gives it radiation. And we're now combining that with some immunotherapy with dinutuximab, the antibody that has been shown to improve survival. And we just finished we call a randomized trial where patients are randomly assigned to one of 3 treatments, Mibg plus something else, to see if the something else made a difference. And we found that this one drug called vorinostat actually significantly improved the response rate compared to the other 2 choices. And so now that's our standard platform for Mibg. And now we're trying to look at that plus or minus the immunotherapy molecule to see, can we bring it up again? In the meantime, actually, Children's Oncology Group is for the first time testing Mibg in newly diagnosed kids. So kids are getting, again, randomized to either get Mibg during their first few months of therapy or not. And we've done a lot of trials in recurrent relapse patients in our NANT consortia. And Mibg is like one of the most active agents for recurrent tumors. About 30-40% of the kids will have some response. So it'll be very exciting to see if that adds into the outcome. And we're looking at adding this antibody dinutuximab into the first few months of therapy. Right now, we've been giving it after you get all the intensive chemotherapy, then they get a period of 6 months of immunotherapy. So now we're saying, well, what if we give it sooner? And we've found in recent years that giving that antibody with a I realize when I say easy chemo is never easy, relatively, low intensity chemo. Has a tremendous response rate. Like about 50% of kids who have recurrent tumors will respond to this chemo with the immunotherapy. So we're trying to figure out, why, how is that working together, and how can we maximize that? Maybe adding in, something else that would promote the immune system. I mentioned we're looking at natural killer cells, which are kind of fun name, but these are cells that are in all of our bodies that can attack foreign things, including cancers. And we know in neuroblastoma, they can be very effective and they can work with this antibody that we know is effective. And our chemo and things can bring down the number of natural killer cells. So we're trying to infuse more to help the patient. So I think that's exciting. And you may have heard about CAR T cells. This is a very exciting technology. So I always think people picture like a car, and maybe in a way it is. It's a T cell, again, is one of the cells in your bloodstream. It's one of your white blood cells that is part of your immune system that will fight infections, but it also can attack cancer cells. And so what people are doing is taking those T cells and then they're attaching, if you will, like a little targeting agent to the surface of the T cell. So again, it will go into the body through the bloodstream and find the cancer cells. So there's CAR T cells that are specific for certain kinds of leukemia or for certain kinds of solid tumors. To date, we've not found, that has been very effective in leukemia, and it's actually a newly FDA-approved therapy for leukemia, and it's had like an 80% response rate in kids whose leukemia has come back after standard therapy, which is incredible. I mean, if we get more than 20% of kids to respond in that situation, we're thrilled, and this is 80%.
Wow.
But they don't all stay there. So there's a number of groups that are working on CAR T-cell therapy for neuroblastoma. And so that's another exciting avenue that I think is, coming down the line. So those are kind of the things that are, out there now.
Cool.
I think all promising. I mean, I think they've, and I mentioned actually the ALK inhibitor, lorlatinib. So we're very hopeful that this is going to be an exciting thing for the kids who have the ALK abnormality.
Well, no, this has been great for me. I mean, as we're going through and having all these discussions with Heather and, what we're going to try to fund this year, it's always great to hear what's cutting edge. And when all of a sudden it pops up, hey, that seems like something of value. So, Doc, thanks for taking the time to discuss neuroblastoma and come on Power Athlete Radio.
You're very welcome. It was my pleasure.
Cool.
Thanks for having me.
If people want to support and learn more, do you have any links, websites, social that they can head to?
Sadly, we do not have the staff. That's a funding issue for social media. We wish we did, but we do have a wonderful website. It's www.nant.org. And there you will find a link to where our sites are, what trials we're running. We had our parent group, including Heather, who helped us, write answers to some common questions about why a clinical trial, what are these phase 1, phase 2, what do all these things mean? So, and I think the biggest thing there for parents or people who want to connect, our operations centers here in Los Angeles at Children's Hospital Los Angeles, we'd always be happy to talk with people who are interested in supporting us. If you have questions about our trials, I'd suggest you contact one of the doctors at the sites that's closest to wherever you are.
Cool.
All right. Thank you.
Well,
Thank you.
here.
Have a good day.
You too. Thanks.